everyone. It's morning time in the States here, probably afternoon time, Dubai time. My name is Adham Alkurashi. I'm one of the residents at George Washington University Hospital, doing general surgery now with plans to do cardiovascular surgery in the future. And today I'm going to be presenting a paper that we've published recently regarding the diagnostic criteria currently for the aortic valve stenosis in patients who have comorbidities such as atrial fibrillation and specific. The main idea of this paper was to show that we're currently referring people to surgery or valve replacement later in their disease course. And probably if we look at the diagnostic criteria, we can kind of send them earlier for surgery and they might have better outcomes. Can we move to the next slide, please? And I promise I'll be as brief as possible. I'm joining you from the hospital today, so. Okay, next slide, please. Okay, so starting with kind of a quick background about the disease itself and why we were interested in this. Atrial fibrillation is very common, especially in the Western countries, such as the United States, and probably there are a lot of reasons. And the one that was convincing for me is that people here get better healthcare and they're living longer than what we see in other parts of the world. So that's why we see it commonly here. And the main way we diagnose aortic stenosis in those patients is with transthoracic echocardiography currently. And there are guidelines that are published by the American College of Cardiology, which we follow. By definition, severe stenosis, which is the focus of our paper, because we're not going to be talking about mild or moderate stenosis, is defined as mean gradient across the valve of more than 40 millimeter mercury and peak velocity more than 4 in the setting of valve area of less than 1 centimeter squared. Next slide, please. Okay, so the treatment for those people who can tolerate valve replacement is valve replacement, whether it's going to be surgical or transcatheter. Our paper will focus mainly on the transcatheter because that was the study population, but I think we can project that to the surgical valve replacement. Next slide, please. This is kind of diagram. I'm not trying to overwhelm you guys with a lot of kind of charts and stuff, but this is what you can find on the American College of Cardiology. This is the 2014 guidelines, which demonstrates what timing patients should be referred for surgery. And it's kind of divided mainly by whether the patients are symptomatic or asymptomatic. So if they're symptomatic and they have the criteria of more than 4 and more than 40 millimeters gradient, they can be referred to surgery, and that can be TAVR or the surgical placement of the valve. If that criteria does not apply to them, we should be looking at the ejection fraction because that can affect the mean gradient and the velocity, as that defined as forward flow across the valve. The other part is the asymptomatic patients, and those are stage B and C, and they have more kind of indications for the surgery, and we should be looking at tiny details here in the chart to kind of see whether they're going to be eligible for valve replacement or not. I'm not going to try to go over everything here, but we're going to be sharing the slides, so if you guys are interested, you can have it. Next slide, please. The main way we diagnose or we measure the gradient across the valve is based on the continuity equation, which is listed in this slide. So we look at the left ventricular outflow tract as well as the aortic valve, and kind of the flow across those should be the same. So we apply the formula listed here, which is the area by velocity that can give us what's the area of the valve, and based on the flow rate, we can measure the gradient as well. Next slide, please. This is how it looks like on the transthoracic echo for those of us who are starting their career as a residents or even early on in their career. This is how it looks like. And this slide specifically is showing how it looks like in atrial fibrillation patients. And that's really important because if we look at those humps that are hanging down, we can see that there is a noticeable difference in the amplitude of those graphs listed here. And that's also what drove our paper to kind of talk about this specifically, because the American College of Cardiology kind of have a specific guidelines for how we can use the transthoracic echo currently to diagnose the severity of this stenosis across the aortic valve. If we can see here, there are like 5 beats listed here, and in atrial fibrillation patients, we take the average of those 5, the mean gradient, and the average, if it's less than 40, then this is not a severe aortic stenosis. If it's more than 40, then this is severe. While in sinus rhythm patients, we only take 3. Next slide, please. Okay, so why this is not helpful when we take 5 measurements and kind of divide them on top of 5 and get the average, because atrial fibrillation affects the cardiac performance. And the way it does that is because the atrium is not contracting, so we're losing it's not contracting regularly. So we're losing the forward flow or the pumping effect of the atrium towards the ventricle. And the other thing is, in atrial fibrillation, patients have a lot of other stuff going on in their heart. Mainly the tricuspid regurg is something that we saw commonly associated with atrial fibrillation. So all of that will affect how much forward flow we have that's going to drive the flow across the aortic valve. Next slide, please. Okay, so here comes our paper. Our paper is saying that the Doppler mean gradient, which is when we take 5 readings and get the average of them, is discordant with the aortic valve calcium score, which is forward flow independent measurement of the valve stenosis, and it has been used commonly for surgical planning. So we've noticed that in patients who are going to have surgery at Mayo Clinic, they used to have a CT scan for kind of procedure planning. And that CT scan was kind of run into like an AI application or a software that can measure the calcium scores across the valve and give you a number that you can kind of correlate with the severity of the stenosis. Next slide, please. Okay, our study population was patients who underwent that procedure between the years 2016 and 2020. And we mainly studied patients with preserved ejection fraction. So patients who have ejection fraction of more than 50 of the left ventricle. We use the current guidelines, which I showed, the ACC guidelines of 2014, which was the most recent one published at that time. Our exclusion criteria was kind of the age under 18. We did not study pediatric population. We were studying adults. Patients with aortic regurg were excluded from our study because that's per se can affect the forward flow, and it can confound the results of our study. Atrial fibrillation was also excluded, so we were just studying atrial fibrillation in particular. And patients who had a redo valve replacement were excluded as well because they can have paravalvular leak, which can affect the forward flow and can confound the results of our study. As I said previously, currently we're using 3 consecutive measures for the patients with sinus rhythm and 5 for the patients with atrial fibrillation. We used the data documented. It was a retrospective study, so we used the data documented in the echo reports for those patients, and we pulled the images from the system and kind of measured the highest amplitude one out of those 5 that we showed earlier. We were using the average of 5, and we were using also, we were comparing that to the highest measurement because our theory is that if the heart is able to generate one high amplitude beat, then that can show us, or like it can scream and say that, hey, I have a severe stenosis if I have mean gradient that's more than 40 in one beat. It doesn't have to be like the average of 5, because the heart can, in atrial fibrillation, the cycles are irregular. And if we have enough time to fill the heart and push forward more blood, then that can show me that there is a high gradient. And we're going to show how that correlates with flow-independent measures of the severity of the stenosis. Can we move to the next slide, please? Okay, as I said, the CT scans were performed for PRES using same softwares that we use for all the patient procedure. So that was our standard of involving patients, because if patients had more than 90 days, they're at risk of having like progression of the severity of their disease, and it's not going to correlate with the echo measurements. So we excluded also the numbers that were included in the reports that represents the aortic root or the outflow tract or the mitral, because those are not part of the study that we're doing here. We're just focusing on the stenosis of the aorta itself. The current literature describes the severe aortic stenosis based on the calcium scoring as more than 2,000 for males units and more than 1,200 for females. So that was our threshold to consider patients as having severe aortic stenosis, and comparing them to the current measurements for the transthoracic echo. Next slide, please. So this is our statistical analysis. I'm not going to go over details here, but we use the standardized pathway. All the nominal variables were described as numbers and percentages. All the continuous variables were described as means and standard deviation when they're like normally distributed, and interquartile range when they were not normally distributed. Next slide, please. So the population of our study after applying all the exclusion criteria was 633 patients. The mean age of those patients were 82, and the females were 46%. The majority were males. The percentage of atrial fibrillation, or the share of atrial fibrillation patients in those 633 were 17%. Aortic valve area index was lower in patients with atrial fibrillation, which can kind of describe what we're trying to describe here, and that was statistically significant. The stroke volume index, the flow rate, and the mean gradient, which are all measurements of the forward flow, were all lower in atrial fibrillation. We were taking the measurement, like the 5 measurements. Aortic valve calcium scoring were higher in atrial fibrillation. It was 3.5 K, while in sinus stratum patients it was 2.7. So when we take the flow independent measurements, we're noticing that atrial fibrillation had more severe stenosis compared to patients. Next slide, please. So here is a table from the study that's kind of describing what I was saying just a few minutes ago. So the things that are highlighted were the things that I mentioned earlier. So aortic valve area index was lower in atrial fibrillation, and we can notice that it's statistically significant. The mean gradient was lower in atrial fibrillation patients if we take the 5 measurements, while if like the line just below that describes the highest gradient, which I earlier mentioned. If you can see here, it was higher in atrial fibrillation, and the peak velocity was also was higher in sinus stratum patients. Next slide, please. Here, we're describing the aortic valve calcium scoring, and we can notice on the left side of the chart that we have males and females. In male patients and those with preserved ejection fraction, more than 50, we've noticed that the calcium score is higher in atrial fibrillation patients. And when we divided the calcium score by the mean gradient as an index of the severity, we've noticed that in atrial fibrillation, it was significantly higher. In female patients, same thing applies, but we didn't reach statistical significance. Probably that's because males were known in the, like, if we look at the literature, we will notice that male patients had more predominant calcium deposition on the aortic valve when they have stenosis compared to female patients. And that's one caveat of this study. Next slide, please. The main points, take-home points from this study was that patients with atrial fibrillation had higher calcium scoring, representing higher severe stenosis, and it was discordant with the mean gradient when we use the current guidelines by dividing on 5 in atrial fibrillation and 3 in sinus rhythm patients. Next slide, please. Looking at flow-independent variables that we can use to describe severity of aortic stenosis, we've used the calcium score in this study. There are other modalities that we can be using, and we've published 2 or 3 papers other than this one, describing other methods, which I'm going to mention at the end, the last slide of this presentation. As I mentioned, atrial fibrillation affects the forward flow by many ways, and one of them is the irregularity of the cycle. Okay, so next slide, please. Okay, sorry. So this slide is describing one of the variables that can be confounding when describing calcium scoring in specific, which is vitamin K antagonists, people who are on warfarin for valve disease or for other reasons, like even for atrial fibrillation, because we know it's common. Vitamin K antagonists were shown to affect calcium deposition in the valve. So we accounted for that, and this is a table that's comparing patients with who are taking vitamin K antagonists versus none. And we can still see that the calcium scoring was higher in the atrial fibrillation patients, even though we're accounting for the vitamin K antagonists. Next slide, please. Okay, next slide, please. Okay, so other studies that we've published describing the same thing using other methodology was the aortic valve weight. So patients who had atrial fibrillation and aortic stenosis and were either had open surgery and had their valve excised, or patients who passed away because of this reason and had their autopsy and the valve was excised and the weight was measured. We used that as another way of describing valve severity, valve stenosis severity when compared to the transthoracic echo. We've used also cardiac catheterization to measure the forward flow and compare patients with atrial fibrillation versus sinus rhythm. Those papers are published, and you guys have access to them. I can send the links. By this, I'm happy to take questions if anybody has any questions.